Good.
Welcome to this episode of the Montpelier Happy Hour here on WVEW LP Brattleboro 107.7, your community radio station, as well as Emilie's YouTube channel and Brattleboro Community Television. I am your host, Olga Peters, and we have on the show this week regular contributor, Representative Emilie Kornheiser, who is one of 3 representatives for the town of Brattleboro, as well as State Auditor Doug Hoffer. So glad you can join us today, Doug.
My pleasure. Thank you, Olga.
And we want to talk about today a recent, I'm going to call it an investigation or an audit that your office did looking at healthcare affordability and particularly Vermonters' ability to pay. And what your office found was that basically the cost of providing healthcare is outpacing basically the growth in Vermonters' wages. And from your 5-page letter that you sent to the Green Mountain Care Board, which is the organization that, for those who don't know, the organization that oversees hospital budgets and a lot of the finances related to Green Mountain Care. This is the line that stood out to me. Absent from the board's regulatory review process, cost growth targets and routine analysis is a clear and direct consideration of Vermonters' ability to pay for healthcare. In other words, the board that is supposed to be overseeing this, in many ways, this issue it hasn't really been doing that. Could you tell us a little bit more about that, Doug, and sort of your office's findings?
Sure, I'd be happy to, and thank you for asking. Obviously, we think the issue is extremely important. It's not going away. It's healthcare in Vermont is about $6.2 billion. It's almost 20% of the state's entire economy. And what we showed, among many other things in the report, is the huge divergence between expenditures for healthcare and Vermonters' wages. But back to the beginning, the Green Mountain Care Board was created about 10 years ago, and the legislature made it very clear what their intent and priorities were. They noted at the beginning several principles that should guide the work of the Green Mountain Care Board. And the first 2 are about affordability, and which makes sense. Why not? When the board was created, we had just completed a 10 or 15-year period where healthcare costs had grown, I won't say exponentially, but pretty quickly and out of control. So, credit to the state and the legislature for saying we need to get this under control. We're going to create this new entity. It's going to have a lot of responsibility. Some would say in the early years too much and not enough resources. Now they have a lot of resources, but they still have a lot to do. So it isn't just hospital budgets, it's also insurance rates, among other things. So they are required to consider affordability. However, a very important decision was made now about almost 5 years ago with regard to the all-payer ACO and also hospital budgets. They set a cost target. And when they did their negotiations with CMS, the Center for Medicare and Medicaid Services, the federal entity, which is bigger than God, they agreed that they would follow the path laid out by Maryland, which some years prior had said, well, we too are concerned about the rapid growth in healthcare, so let's have a target that's more sensible. So what they did is use the annual average change in gross state product, which to a layperson who doesn't follow this kind of stuff sounds reasonable enough. Why not? That's what the economy is doing. Let's make sure that healthcare does that too. Well, the fact is, there is no good correlation between gross state product and wages. State product generally grows much faster than wages. Now, that's a function of the economy over the last 40 years. Post-Reagan, wages have been, not entirely, but fairly stagnant compared to a lot of other stuff. So they adopted that percentage, which was 3.5%. And if you run that out in a hypothetical against wages, you see this immense gap, this alligator mouth here, consuming everything in its path. So that was part of the problem. They used a similar approach to hospital budgets. So we looked at actual expenditures, not the budgets that were approved by the board over the years, but actual. I think you can see it if you have the document there. And from 13 on, I think if I have this right, the actual hospital budget increase was 200 and, no, I take it back, 65%. And wages only increased 18%. That is, for lack of a better phrase, an affordability gap. Now, not everybody pays at that rate. Many people have insurance, many people have good insurance. A lot of people don't have good insurance. A lot of people are grossly underinsured in because their employers, for those lucky enough to have employer-assisted healthcare, have also been struggling with this because the board, and this is sort of an oddity in statute, they are required when reviewing hospital insurance rate requests to make sure that the insurer is viable and doesn't go belly up. And we appreciate that. You don't want to lose Blue Cross Blue Shield if it's the major commercial insurer in the state. However, to say that you're balancing that with affordability when it comes out to that kind of a gap, then it's not working. It's clearly not working. And what happens as a result of the rates going up are a number of things. One, employers are required to keep paying those rates. So they have a couple of responses to that. One is, my goodness, we're going to have to buy a cheaper policy. What that usually means for the employee is a higher deductible. With its own problem. People put off healthcare because they can't afford to meet the deductible, or they reduce wages. So it's a problem, and that's what we saw in looking at this work. So the board. I'm not trashing the members of the board. They're all smart, well-intentioned people, but they haven't been, in our opinion, and as the evidence suggests, they have not been seriously considering affordability.
And for listeners who are tuning into this conversation for the first time but are interested in this topic, we spoke to the healthcare advocate, Mike Fisher, about sort of that definition of affordability in the eyes of the Green Mountain Care Board and how different that might be from how you and I might understand affordability as something that might be linked to our ability to pay, perhaps. So
yeah, Mike Fisher's been very good about this over the years. Yeah.
Can I, when I think about how expensive the cost of healthcare is, or even the bill that someone gets, which might not match up with how much they're paying, but they know their insurer's being charged, where does the money go? And when I ask, on a national scale, I have a better sense of how to answer that. There's a lot of publicly traded companies where they're shareholders, they're CEOs. And I know that CEOs in Vermont make an enormous amount as compared to the average Vermonter's wage. But it doesn't seem to me to be enough to be making up the difference in how much money seems to be flowing into the system. So, and we have nonprofit, everyone's hypothetically a nonprofit in the system. So where does the money go?
Well, that's a very good question. Almost half the money goes to hospitals, which shouldn't be surprising. We have a lot more people getting care in hospitals than we should. Part of the goal of the all-payer ACO, for what it's worth, and we can talk about that later.
Yes, please.
Yeah, is to reduce utilization of hospitals and increase people's preventive care and general health. So they won't need as much health care, particularly hospital-provided health care. The hospitals, as we reported in another report about a month ago, have been aggressively buying providers.
Yes.
Independent doctors' practices, individuals and half dozen or more in a practice. So that today, I think it's 83% of all doctors work for hospitals. Now, if Emilie, if you were a doctor yesterday on your own,
Please.
I could go to your office and you would provide a service and it might cost $200. If after your practice is purchased by the hospital, and I can appreciate why that might appeal to you, less overhead, you don't have to pay the insurance, whatever, you have predictability. But now when I go to you, not only do I pay the $200, but I have to pay a facility fee. For example, Fletcher Allen, of course, not in your part of the state, adds on to your bill that I have to pay, whether I go to the hospital or not. So and they would argue, and they have argued, that some of that is because Medicare and Medicaid, they would argue, don't pay what it actually costs to provide services. What's interesting is that is a self-attestation by a self-interested party. They say this procedure costs $10,000 and Medicare will only pay us $6,500. Should I believe them that it costs $10,000?
Well,
Why?
no, you should do an audit of it.
Because they said so? So what happens is they say, well, there's a gap.
Mhm.
It's a very significant gap globally. So what they do is then charge the commercial insurers more
To make up the difference.
Right.
And so then what happens as we have more and more Vermonters on Medicaid and Medicare, which is the direction we've been going in demographically?
It exacerbates the problem for sure.
So if the money goes to the hospitals, most of it, to perhaps cover the costs and the difference between some insurers and other insurers, is that just, the hospital budgets are, if you audited them, they would be reasonable, costs would be covered, money isn't flowing? Is there money flowing out of the state in large quantities? Where does the money, once it goes into the hospital, go? And I'm sorry if I'm asking you questions that you haven't actually done a study of. This is like, it seems like people talk about it as if it's a vast conspiracy, and I imagine that it's not, and there's a reasonable explanation.
I don't think.
And the explanation might be rampant capitalism, but that's an explanation too, right?
Well, powerful institutions tend to look after themselves.
Yes.
In the last report we did, we referenced peer-reviewed literature that makes it very clear that while hospitals and others and analysts, independent analysts would say, if a hospital expands and buys practices of different natures and is vertically integrated, that can and arguably should produce savings. Furthermore, if hospitals buy other hospitals, that too, in its own way, should produce savings. It can also, depending on the circumstances, like Vermont, where we don't have the kind of competition that, say, Boston has, with half a dozen literally independent major hospital institutions. So there's real competition. When there's no competition and those circumstances are as they are here, they have immense power to control prices.
Mm-hmm.
Unless there is a regulatory entity with real backbone.
Mm-hmm.
And I'm afraid, with all due respect, that we don't have that,
Mm-hmm.
in my opinion. And the evidence suggests that they have not been able to control costs or prices, which is unfortunate. And, they would say we have to keep the hospitals viable. True, we have to keep the insurance companies viable. But the all-payer ACO is a legitimate attempt to address the problem of fee-for-service medicine, which is doctors and hospitals doing more tests than is required just to protect themselves. So that's fine. But that itself doesn't address the much bigger question, which I don't know enough about, which is our hospital infrastructure what we need?
Mm-hmm.
Refer to them as community hospitals. And of course, what community, usually a county, doesn't want a full service hospital that can do anything and everything whenever you need it? I understand that. I appreciate that. But a lot of the services that we get over time are not emergency services. They're planned procedures, a knee replacement, whatever the case may be, all kinds of stuff that maybe you don't necessarily have to have all those capabilities at your local hospital. And I'm just talking off the top of my head here, but we haven't yet had that conversation globally. That's a hard conversation to have because then you run into what? A very powerful vested interest, which is the Association of Hospitals.
Mm-hmm.
And
as well as if you're going to pick a hospital, which hospital do you pick and what political gravity does that attract to that area or away from that area? When I talk to doctors or people who get a lot of procedures, they tend to want to be, for a particular procedure, usually you want to go to a doctor who's performing that procedure often. And in a rural context, that's not really possible because there just aren't enough people needing whatever that procedure is. So in some ways that makes sense, but then we lose that deep sense of sort of that community center, that community health center, which is different from a hospital. And I think perhaps we have some evolution of definition here. So,
well, and I think there's also the issue when a hospital starts deciding which procedures it will and will not offer. That also determines which part of the community it's serving. For example, and this is not to pick on Grace Cottage, but as far as I understand, it no longer offers maternity services. It no longer delivers babies. And that was a decision it made for very good reasons. And with BMH nearby, it makes sense. But then that means also, what if we have a lot of young families coming into the area served by Grace Cottage? What if they want or need maternity services? And again, I'm not picking on any specific hospital, but it does beg the question.
Well, this is a conversation that Vermonters should have together.
Mhm.
It should not be driven by the hospital. It's now been over 30 years that the Public Service Board turned the corner and said to the utilities, CVPS, GMP, Burlington Electric, in my case, and others, we're not going to approve any of your power purchase contracts until you demonstrate each time that you're investing in energy efficiency.
Mhm.
Their livelihood, their whole raison d'etre all along was just to sell more KWH, period. The line for that was up forever. Every utility analyst said, well, we're going to need more and more and more and more.
Mhm.
And the board wisely said, no, you're delivering services that can be provided with machines and equipment that use electricity, but you have to do it more efficiently. And the utilities went, wait, that's not what we do. We sell KWH. So it required a complete change in their view of their own business. Now, I'm not here to tell doctors and nurses what to do. That's not what we're talking about. But it's about infrastructure. It's not dissimilar, Emily, you might agree, with some of the problems that the Vermont State Colleges are having. Decisions were made many years ago about their infrastructure, both infrastructure and how they would utilize each location for what purposes. They all seem to want to be a mini 4-year BA experience, and maybe that wasn't what was needed in each community. So I think we need to have that conversation.
And in that conversation, and I entered it fairly late because we don't have any of the state colleges down my way. And so I was able to be a few steps back from the conversation, which was nice because it was quite intense. But I don't even understand why UVM isn't part of the Vermont State Colleges system. Like, none of the way that it was built, it seems very irrational from the outside, all these years later. And I think our hospital system is similar. When I think about the power of our regulated utilities, and if we think of healthcare as a utility, in some ways we could imagine OneCare as that mandate towards efficiency, right? To reduce costs and services. But it wasn't set up in quite the same way. And I think there might be, it's my understanding is there isn't really a cost savings with the way OneCare is operating right now.
There's supposed to be.
Yes.
That was the goal. And at the end of each year, they measure the shared costs or savings. And by the way, just today or yesterday, the board released the Medicaid results for 2019. And you know this, Emily, that your viewers might not. Each year, in collaboration with the state and the board, OneCare sets out what their goal for the year will be. X hundreds of millions of dollars on this particular population.
I'm realizing that we should step back even further and explain what OneCare is.
We had a 70-page report to to do that.
Yes.
Okay.
I'm going to try just a very broad 2-sentence bucket here. The idea is that a lot of the drivers of healthcare costs in Vermont are driven by sort of downstream interventions, the kind of things that require hospitals. And if we wanted to save money and have a healthier population, we need to take some of that money that we're spending downstream and move it a little further upstream into prevention work. And so a few of the big players in healthcare, this is a very optimistic version of the situation, a few of the big players in healthcare came together and said, we are going to invest a significant chunk of money into this prevention model, and we're going to bring in a certain number of patients or Vermonters each year to say, we now get healthcare within this system that really focuses on prevention. And eventually that savings from investing in both prevention and intervention will pay off, and we will be a happier, healthier, more healthcare affordable state. but that doesn't quite seem to be working.
No, what they do in practice is say, even though they haven't met their goals for the number of people, patients involved, which are called attributed lives, they use some pretty reasonable data to say those 150,000 people should cost, pick a number, $250 million next year, based on historic stuff and so forth, and the investments you're talking about. So we're going to give providers a payment per member per month. And you're going to have a pot of money, and you get to use that money any way you want. And the goal is for you to get people healthy and keep them healthy. And at the end of the year, we're going to find out, did you spend more or less than we estimated going in? And if we spent more, then you're going to be responsible for some of that overage.
Mhm.
If it costs less, you get some of the savings. That's the way it works. And the report that was just released found that last year, One Care Vermont missed their target just for Medicaid by $12 million.
Mhm.
So, and that's not the first time. Things aren't going terribly well. And that doesn't include One Care Vermont's administrative costs, which were about $19 million. So there's a lot wrong with this picture so far.
There's a lot wrong with the picture on the administrative costs. There's a lot wrong with the picture around, I think, people's ability to opt in or not, and the mandate related to that, and regular Vermonters' understanding of what they're opting in or out of. I also have a lot of, I guess I'm going to use the word compassion for being held accountable for something on a year-to-year basis that really should have like a 30-year turnaround. And so I'm not sure whoever agreed to those outcome measures, but they seem, you don't invest in prevention 1 year and have the same, and like have someone be healthy that year. That's not really how bodies work, right?
No, that's fair. And it won't surprise you to know, your viewers, you probably know this, Emilie, that the contract also has a bunch of so-called quality measures. And if you meet those targets in quality, having nothing to do with dollars, then you get bonus points.
Yes.
And that is rolled into the estimate of shared savings or costs. And nobody would argue with the fact that the front-end interventions will take time to evidence savings and better health and better life and so forth. But in the near term, they're saying that the other stuff that is happening in real time, better coordination between different providers, sharing of information, reduced unnecessary tests, all that stuff should be producing results now, and it's not.
No.
On that note, we're getting close to time where we need to break here on WVEW. But one thing I find, I don't know how this situation manifests for either of you, but I know for me how the affordability issue kind of manifests is that, I can easily go to my doctor. I've got the money for that. But it's the ongoing preventative things, like lab work particularly, that is the hardest thing to keep paying for. And I find it so interesting, if we want to be preventative, that something like that, like a blood test, can be hard to pay for.
Mm-hmm.
You're absolutely right. I agree.
On that note, we are going to hear from some of our underwriters here on WVEW 107.7, Brattleboro's community radio station. Representative Emilie Kornheiser and State Auditor Doug Hoffer and I shall be back in a moment.
Back we are.
We are back to the second half of the Montpelier Happy Hour here on WVEW LP Brattleboro 107.7, your community radio station. I'm your host, Olga Peters, and if you are just joining us, I'm speaking with regular contributor, Representative Emilie Kornheiser, as well as State Auditor Doug Hoffer, and we are talking about, yay, healthcare and healthcare costs and Vermonters' ability to pay, which once again, we're coming up against that word, Emilie and Doug, affordability. And what does that mean? Before we dive into that though, Doug, I'm curious, if the Green Mountain Care Board, and I'm not sure how deeply you can answer this question, if the Green Mountain Care Board is supposed to oversee some of these costs and affordability. You know, what has broken down in the system that it hasn't happened?
Well, first, as we point out in the report, they have not, to date, established any affordability metrics to measure their work against. That's one.
Gotcha.
The other is, to be very honest, and Emilie used this word earlier, and she's absolutely right. This is about power, and I don't mean utility power, as we were discussing before. But you know, hospitals are arguably, along with electric utilities and a few others, the most powerful entities in the entire state. And you know, for a regulatory entity to feel comfortable reining them in and using all of the available powers in statute, they have to feel, I would imagine, like the legislature has their back.
Mhm.
And I'm not sure that's the case. No disrespect, certainly not to you, Emilie, but I don't see much evidence in the last few years that the legislature is even focused on this issue. Furthermore, I don't see any evidence that the administration is focused on this issue. I think after Peter Shumlin's unfortunate experience, our total experience in the effort to move towards single payer collapsed, not because it couldn't be done, by the way, but because there was no will to do it, no political will. I think everybody feels like, wow, that is the third rail. I'm not going there. So you have committees of jurisdiction that they hear from healthcare providers and hospitals and insurers all the time, but I've never heard them say, boy, we're really not making progress. Board, what other authority and resources do you need? How can we move forward on this? And how can we have a broader conversation and agree on how to proceed? So that's
I would, so very interesting to me, you know, the myth of the legislature is very powerful, the myths that move through the building, right? And being new, they're much more apparent than I think after you've been there for a while, where they're just sort of the stories that you tell at bedtime. And the two that have stood out the most to me in my time there are Shumlin stepping back, and sort of the hope that people had, and then the feeling that people were left with when it didn't work. And how much so many people believe that because something didn't work then, and they had hope and the hope collapsed, and how emotional that reaction is, how impossible it must be now. And then the second thing that people is like the strongest myth is the folks who voted for civil unions, or even the folks who stepped in after into seats of people who had left because of their vote for civil unions, and how much people still thrive from that courage, that incredible courage that they feel they had in the moment. And how many years later, and that's still the most poignant memory. And so I think about how can we take that poignant memory of civil unions and carry it into, I think, the issue that is probably singly most important to Vermonters at this point in terms of costs, which is healthcare. And even if we, you know, for Shumlin, maybe the dollars didn't quite line up, or the political will didn't line up with the dollars, but people are spending significantly more money on their healthcare now than they were then. And so if people need to make a little, businesses might need to pay a little more towards that, but they're paying so much right now that I imagine it's a different equation and a different conversation if we could find the political will to restart that conversation.
Well, that's a wonderful characterization of it, Emilie. I think there's a significant difference that you probably will agree with me on, and that is that the courage required to do civil unions and gay marriage, while significant, did not require overcoming economic power.
Yes.
Mm.
Oh, yes.
That's sort of the roadblock for everything, not just in Vermont, but every state in the country. And that's the kind of power we're talking about here. Now, I don't want to diminish what they accomplished. In fact, overcoming cultural bias like that's a big deal, a very big deal. And thank goodness they did it. But this, like our conversations about economic development, there's a wall. For some reason, most of your colleagues are unwilling to touch that wall.
No, it's very interesting how when I think about especially the Democrats, but I think this is true across party, how sort of the definition of what left politics look like is very comfortable on issues that don't cost anything and very difficult on issues that cost something, and how much Vermont's sort of inner conservative spirit comes out in those conversations. So let's say the Green Mountain Care Board was going to regulate healthcare in a much stronger way. What is the blowback that they're scared of and anticipating? I mean, is it the threat of hospitals closing? And I know this is sort of asking you to project beyond any audit report, but is it the threat of hospitals closing? Is it the threat of insurance companies shutting down? Like, what is on the other side of that hammer?
I think both are considered legitimate possibilities, but also in the near term, you saw what John Brumsted did. The board had an order with regard to the hospital budgets that basically said, you know, we're going to do something that you're not going to like, but we think it's appropriate. He basically come out and said, you're breaking the rules. We had an understanding. This is the world we live in, this little narrow space. You went outside that, and the board, I won't say caved, but they backed off. Remember, what they do is they respond to submissions by the hospital. They give them guidance. Each year, there is hospital budget guidance, and it includes this target, this 3.5% target. Well, why are we using a 3.5% target? That is a much faster growth than almost everything else in the economy, right? Including energy prices.
Yeah.
Why do we accept that as appropriate?
Mhm.
We need to accept that. We should have a conversation with the hospitals that says, of course, we don't want to lose hospitals. Our communities need you guys and your services, but maybe they don't need to look the way they look today. And if they looked a little different and we made a joint commitment 10 years from now, maybe they would look different enough that we wouldn't need 3.5%, that your expenditures could be brought into line with what people can afford. But that's not the conversation they're having. They're saying, come in at 3.5%.
Mhm.
I'm sorry. What other industry gets to do that? Say it with
Certainly not the industry that pays me. So
Same here.
But you know, the Public Utility Commission operates in the same way in that they receive all of their materials from the utilities and negotiate the rates from there.
but
And so are you saying the difference is that definition of affordability is much tighter for the Utility Commission?
I think it is. And furthermore, while the Public Utility Commission does allow, this is true all over the country, a predictable profit margin, that's not the same as 3.5% growth every year.
Mhm.
If the utilities come in and say, boy, look, the purchase power next year is going to go up a lot, they'll say, okay, how are you going to save Vermonters money on the other end with efficiency?
Mhm.
Now they invest that to a large extent in the creation of Efficiency Vermont, which a lot of Vermonters don't understand and hate. They don't at all, but it has saved enormous sums of money. So the Public Utility Commission has a lot of levers and tools. The
Mhm.
board has some of those, but they're not using them. Do you know that the board can set prices at hospitals?
I did not know that.
They have the power to do that. They're not doing that. I mean, that's my point. I'm not sure that they have taken advantage of all the tools at their disposal. And I'm not being disrespectful. Sorry about the phone. But there needs to be a conversation, and it should start with the committees of jurisdiction.
Mhm.
And if it were me and I was on that board with Kevin Mullen and his colleagues, I would say they should start that conversation. If nobody else is initiating it, then let them do it.
So
Not
I
doing it.
might be getting a little too geeky about organizational forms here, but when I
Okay.
think about the point of, you know, the value of nonprofits versus for-profits and how they provide stability in an economy, it's the idea that they don't need to see growth year after year. That you know, impetus towards year over year growth is particular to the for-profit model, and it's one of the reasons that nonprofits are a useful mechanism in our communities. And so why do they need to, how do they even justify that they need to be seeing that growth year over year?
They would tell you that their costs go up that much.
Yeah.
That's it. You know, you said earlier, you know, why don't we do an audit of hospital budgets? Well, that would require expertise that we don't have in-house.
Mhm.
By statute, our funding source, the single audit revolving fund, could pay for that expertise.
Mhm.
But absent action by the legislature, the hospital could deny us access to the necessary data,
Mm.
which is why I proposed through Ann Donahue H181 that your colleague Bill Lippert put on the wall and just ignored. So
And remind us what that is, H-181?
The auditor's office has very explicit authority in statute to obtain literally any information that is produced in or obtained by state government in the course of its business, including confidential data, as long as we don't then make it public ourselves. Personnel data, tax data, HIPAA, which is healthcare data, all of that, we can get anything, and we routinely do. And we keep it confidential as need be and tell a story without disclosing. However, even though contracts with the state include audit provisions that say routinely, the auditor's office has the authority, or you have to retain materials necessary for the request of the auditor to determine your performance under this contract for at least 3 years, if not more. If we went to the hospital and said, we'd like this much information, they'd say, well, almost none of that is related to our performance. Who are you kidding? We're not going to give it to you. And then we would have to go to court. So I went to the legislature and I said, I know how they're going to respond when it comes to that day. They have an army of lawyers. So why don't we just deal with that now and expand our authority to include explicit authority by my office to get this kind of information. We're talking about entities which receive hundreds of millions of dollars of taxpayer money, Medicare, Medicaid, and so forth. And the legislature said, we don't think that's necessary. At least the chair of the committee said that. I don't. Others might have said the same.
It's interesting because if hospitals' costs were going up at that same rate every year, or if that growth was going back into wages, then we would see, and we, given the percentage of wages that Vermonters earn from healthcare jobs, you would think that that means that wages would in fact keep some degree of parity with the growth in the healthcare industry, but we are seeing that that is not happening. So
no, they have seen in the report we did a month or so ago, we looked specifically at the median wage for half a dozen significant healthcare related occupations and compared them to those in metropolitan areas outside of Vermont. And we are, as with almost every occupational title, we pay much less than our competitors do. To answer your earlier question about why is it so expensive, it's not because the workers are getting paid so much money.
No, it's not.
There are some very well-paid administrators. The vice president for communications or public relations is paid $500,000 a year. And there's a dozen.
Olga, wrong job you're in.
I am so in the wrong job.
So I don't want us to run out of time and not go back to something that you said about single payer and how it is possible still.
Yeah.
So can you talk about that a little bit more?
It's my understanding that when Governor Shumlin pulled the plug, the analysis had not been completed. What happened is, for a period of months, as I understand it, many people in the business community were letting him know that they didn't like the direction it was going in. And there was this belief, which is heard routinely all over this country, this, oh my God, we can't afford this. Look how we'll have to raise taxes, completely ignoring the truth of the matter, which is we won't have any more premium.
Yes.
You know that. But those folks,
I'm very aware of my premiums.
he said, the way to get this done is to have everybody buy in, and they weren't buying in.
Right.
Unfortunately. Having said that, for a small community like Vermont, 30,000 people, it would be a challenge. It would make more sense, it seems to me, to do a regional.
I was just going to ask about that, if regional would be a better way forward.
Whoever's elected governor should be asked, will that be your first and most important effort after you're inaugurated, to talk to your colleagues, your sister states here about that? When Phil Scott first ran, he made a big deal. Remember, on the heels of the Vermont Health Exchange and the problems we had there, he said, clearly it's broken. We made a mistake. We should either go with the federal plan or Connecticut or whatever it was. Since then, silence. Where's the commitment to that? I'm not picking on him. I said the same thing about some of your colleagues, Emily. So
yeah, no.
Yeah, it's unfortunate. We're not making progress. We're going the wrong way. And I had the temerity to say that.
I want to circle back to this issue of affordability, because it seems to permeate so many of the conversations Emilie and I have. And so my question for you, Doug, and you can keep this to healthcare or you can broaden it out, you know, from your perspective as someone who has dug into so many different Vermont programs and parts of kind of the Vermont system, what are you seeing as any barriers to affordability? And like, what are some concrete steps maybe the state should be taking to make things more affordable for Vermonters?
Yeah, that's easy for me. As the guy who wrote the job gap study starting 23 years ago, I understood at the outset that we were going to estimate the livable wage. And in order to do that, we had to create what we call the basic needs budget.
Mm-hmm.
No frills, just a basic needs budget. And then I knew people would say to me, well, Doug, you know, if we can't mandate a livable wage, what is the state to do? And I said, that's really not that complicated. The major line items in a family budget are very simple: housing, healthcare, and childcare for those with kids. That eats up an enormous percentage of the typical household's budget. Luckily, we know how to do some of those things. Vermont is with many, many states in the human and physical affordable housing infrastructure that we have. It's staggering how much good we've done on affordable housing. Having said that, we still have a huge gap, but we know how to do that. We have the property transfer tax, the Vermont Housing and Conservation Board and Trust in Burlington. Almost 30 years ago, we adopted inclusionary zoning, which I'll encourage you to talk to your town about.
We have it. We actually have it in Brattleboro too. I think.
Yeah.
There's a lot of things that we know how to do well, including perpetually affordable housing. The governor never talks about it. He says, oh, you know, we'll have some workforce housing, but if the first buyer, say you, Olga, if it's affordable to you at, pick a number, 80% of median, you live there for 10 years, but your family grows, now you're ready to move out, get a bigger place or whatever, you want to take all that equity out with you. But if you do that, it won't be affordable to the next family. So Champlain Housing Trust and others have this old land trust model, which is brilliant. They retain some of the equity in the property.
And some of the detail that got lost in the housing funding debate early in the pre-pandemic and early in the pandemic is most of the governor's proposals around housing were not perpetually affordable. They were short-term affordable to sort of clean up streets, but were not going to be perpetually affordable. So it's sort of sending state dollars out there that are not going to continue to serve the public good. When I think about affordable for me, it's, you know, if the cost of healthcare is able to go down or to be transferred to a public good, then it's more affordable for employers who can then pay higher wages, and people don't need to make as much because they're not paying healthcare costs out of pocket. So it's a win-win. And I think childcare is really entering that realm where businesses are very, very ready to say, we are losing staff, we are losing hours, we are losing efficiency because of the childcare crisis. So we will actually save money as businesses that we can turn into wages if the childcare crisis is solved. And so that's another way that affordability, providing a public service, makes costs both more affordable for the employee and the employer, who can then move it into wages again. So it's those virtuous cycles are the best.
I'm so glad you mentioned that. About 20 years ago, I did a job for, in fact, a Windham County-based childcare group, which I think is still around and very prominent. I didn't have kids. I knew nothing about childcare, but I learned some things. And even today, the federal government's at the table with money that's used for subsidies. The state supports subsidies. The parents spend whatever they can. Everybody's maxed out except one party. And this is typically not the way childcare is perceived. We know it has tremendous advantages for as early childhood education, for socialization, preparation, all that good stuff. But nobody talks enough about the fact that the labor market doesn't work without childcare.
And if, well, you know, in the list of things to thank the pandemic for, along with comfortable pants, I want to thank the pandemic for this latest number of the fact that 80% of the people who left the workforce last month were women is stunning, horrifying, terrifying, all of the words, but also a really clear clarion call that the workforce suffers when childcare, and humans and women especially suffer when childcare is not taken care of. And so you know, it's amazing how many times we have to have these conversations in different contexts for them to stick, but I do feel like it is a little stickier right now because of the pandemic.
I would add, and I know they are not apples to apples, but along with childcare, I would add elder care. Because we do have an aging population, and so many families are sandwiched between caring for their children and caring for their aging relatives. So I would throw that in there as well.
Very good point.
Absolutely.
Childcare, real quick. Your comment, Emily, about the need for it from the employer's perspective. Back when I did that work, within a year or two prior, the governor of New Hampshire, of all places, brought together a business group and said, I want to know what the cost to the state is and to all of you for not having adequate childcare, not enough slots, too expensive, and so forth. And they came up with a staggering number in the multi-billions, and this was 20 years ago, of course, twice our size. And they understood, the uncertainty for the parents, absenteeism, late to work, all this crazy stuff that Vermont has never quantified or attempted to quantify. I think it could be very helpful in the debate.
I think Let's Grow Kids has gone a long way in quantifying that. And this last year on commerce, we were able to bring together the chamber and the regional development corporations and a bunch of different sort of players in the business space who all said that childcare is the single most important issue we need you to solve, Commerce Committee. And I said, great, let's take all of our money that's in the budget that's usually allocated to commerce and let's put it to childcare. Is that okay with you all? And they said, no, we want you to also pay for all the other stuff. Which, everyone wants all the cake and that's great.
That's the problem. And
that is the problem.
I have a suggestion they won't like, and it is not my business as auditor, so I'll take my auditor hat on and put on my citizen Doug hat. In my view, childcare is no less, perhaps even more important than unemployment insurance and workers' comp. And if you accept that, then you begin to think about, well, how would we pay for that? How would we find the money? Because childcare, like so many other things, requires money to fix or to expand.
Yeah.
And if you were to have a fund that required every employer to pay 5 or 10 cents an hour, the fund for every wage earner, it would raise tens of millions of dollars. Yeah. Now, that by itself is not going to solve the problem, but that would be.
And payroll taxes are a political nightmare.
Yes.
But continue on. I think it's a great idea.
It wouldn't be a payroll tax. The employers would pay it.
Okay.
Directly, as they do for workers' comp and unemployment.
Okay.
It's not enough to make a difference in cross-border wage stuff. 5 or 10 cents an hour is nothing. Right. I'll take my citizen Doug hat off.
You could call it your politician Doug hat too. You are running for office after all.
We are coming close to the end of time. So I just want to touch in with you, Doug, quickly. Any closing thoughts you want to leave our listeners with?
Yeah, the thing that is most needed, in my view, is for the legislature to take this more seriously than they have in the last few years. So I would encourage, Emily's already there in her own mind, although she's not on one of the committees of jurisdiction, but those are her colleagues.
Who knows what committee I'll be on next year too.
I would encourage your viewers, friends and neighbors to contact their reps and senators and say, hey, what have you done about healthcare affordability? Not to call them out, but to say, come on, we're not making any progress. Look at the report that the auditor just did. Because they have the power.
Thank you, State Auditor Doug Hoffer, for joining us today. Remind us, where can people find some of the reports that you have done?
On our website. Go to vermont.gov, and all the statewides are on the main government page, and you can go there.
Fantastic. Emily, do you have a toast for today? If not, I do.
Go for it. If you have one, I can come up with one.
So I want to toast to this deeper conversation of affordability. And
I think Doug needs to find a cup.
Oh,
you have one nearby? You don't? I'm so sorry.
It's quite all right.
A pen, maybe.
A pen. Yes, the pen is mightier than the sword. Toast to this deeper conversation of affordability and how so often in Vermont, we don't have the conversations we need to have on this deep level, but how excited I am because it seems like we are starting to have them more. And I hope we just continue that good work.
Well, thanks to the two of you.
Cheers. Thank
Thank
you,
you.
Doug.
Cheers. And on that happy note, that is all the time we have, beautiful people, for today's Montpelier Happy Hour here on WVEW LP Brattleboro, your community radio station. We air 2 p.m. on Fridays, or you can also find us at the Vermontitude Facebook page, the Vermontitude SoundCloud page, and Emilie, where can people find you?
Folks can find me at emiliekornheiser.org, where you can find my Facebook, Instagram, Twitter, newsletter feeds, and you can also attend my weekly community conversations every Saturday at 10 a.m. via Zoom. Login information for that is in any of the other places I just mentioned, and I hope to someday see some of you in real life again.
Thank you, everyone. Thank you, Doug. Thank you, Emilie. Have a great weekend.
Thank you both. Appreciate it.
Thank you.